If you want to learn everything you need to know as a nurse about venous gas emboli, then this is the video for you. A venous gas embolism is a condition in which air or gas is introduced into the venous circulation where it forms gas bubbles in the blood. These gas bubbles most commonly travel through the venous circulation until they reach the pulmonary circulation, where they become lodged within smaller vasculature. It is, however, important to note that these gas bubbles can become lodged anywhere in the venous circulation. Where they do eventually become lodged, they result in inflammation and block venous blood flow. When a venous gas embolism blocks blood flow within the pulmonary circulation, it causes a ventilation-perfusion mismatch, also known as a VQ mismatch, alveolar dead space, and increased resistance in which the right side of the heart needs to overcome to pump blood to the lungs, also known as pulmonary hypertension. Depending on the severity of pulmonary hypertension, the resistance the right side of the heart needs to overcome can result in right-sided heart failure, called cor pulmonale, which subsequently can cause a decrease in cardiac output. And finally, venous gas emboli can become arterial gas emboli in the presence of a cardiac septal defect. Or in rare cases, gas bubbles can pass through the pulmonary circulation into the arterial circulation. Arterial gas emboli pose a severe risk for morbidity and mortality. If you want to learn more about arterial gas emboli, then click the link on screen or in the description down below. Luckily, most venous gas emboli are easily reabsorbed or diffused across the alveoli to be exhaled without causing any problems. However, the larger and greater the number of gas bubbles, the more likely it is that it will result in life-threatening complications. A venous gas embolism can occur anytime air or gas is introduced into the venous system. The most common causes of venous gas emboli are due to medical or surgical interventions, also called iatrogenic. Air can enter the venous circulation during central line placement or removal, intravenous infusions, or medication administration, and hemodialysis. Surgical procedures that pose a risk for venous gas emboli include surgeries where patients are placed in a seated position, also called Fowler's position, such as some craniotomies or ear, nose, and throat surgeries. Additionally, surgeries that require the inflation of a body cavity, called insufflation, such as laparoscopic, hysteroscopic, and urethral surgeries pose a risk as well. And finally, decompression sickness, a complication of diving, can also cause a venous gas embolism. If you want to learn more about decompression sickness, then click the link on screen or in the description down below. Signs and symptoms of a venous gas embolism vary from asymptomatic to severe. Those that do present with symptoms present with pulmonary embolism-like signs and symptoms, such as varying degrees of respiratory distress, tachypnea, poor oxygenation, a cough, chest pain that is worse with breathing, and tachycardia. If there is cardiac involvement due to right-sided heart strain, signs and symptoms may also include lower limb edema, hypotension, dizziness, and syncope. Diagnosis of a venous gas embolism depends heavily on a history and physical exam. This is because a venous gas embolism is difficult to diagnose due to a lack of specific diagnostic criteria or tests. Rather, diagnostic tests are completed to gather information to either prove or disprove the diagnosis. Tests that may be completed include an X-ray or CT, general blood work, an echocardiogram which may show air in the heart chambers, and an ECG which may show right-sided heart strain. Treatment of a venous gas embolism is focused on stopping air entry if possible, early intervention, stabilization, and recompression therapy for severe cases. Early intervention is important to decrease morbidity and mortality. Patients should be placed in a left lateral position as soon as possible if a venous gas embolism is suspected, as doing so traps the gas bubbles in the right side of the heart. This prevents further gas bubbles traveling to the pulmonary circulation. If a central venous catheter is present, a doctor may advance the line and attempt to aspirate the air from the right side of the heart. Stabilization focuses on airway and breathing and can range from supplemental oxygen to mechanical ventilation. Additionally, inotropes may be used if heart function is compromised due to right-sided heart strain or cor pulmonale. If you want to learn more about cor pulmonale, then click the link on screen or in the description down below. And finally, recompression therapy in a hyperbaric oxygen chamber can decrease the size and assist with the reabsorption of gas bubbles and correct hypoxemia. A hyperbaric oxygen chamber is a controlled high-pressure environment that provides 100% oxygen. This therapy is generally utilized for severe cases of venous gas emboli, or those that develop into arterial gas emboli. Prevention of iatrogenic venous gas emboli focuses on safe venous access device practices. This includes laying patients flat, also known as supine, and having them hold their breath while bearing down, known as the Valsalva maneuver, while removing central lines. Removal should be avoided during inhalation. Additionally, intravenous lines should be assessed for air, that all connections are tight and needle hubs are occluded. This wraps up everything you need to know as a nurse about venous gas emboli. I hope you found this video useful, and if you did, please show your support by giving this video a thumbs up, subscribe, and hit that notification bell so you never miss a video. And please leave a comment down below if you have any video requests. Thank you, and bye!